Hello and welcome to the online lecture on neurological dysfunction. In this first mini-lecture, we'll discuss altered level of consciousness. Altered level of consciousness is present when a patient is not oriented, does not follow commands, or needs persistent stimuli to achieve a state of alertness. Altered level of consciousness is a symptom rather than a disease, and is often the first symptom of neurological compromise. Level of consciousness can be imagined on a continuum, starting with alert and oriented, then progressing to confusion, then lethargy, then stupor, then comatose. There are some specific variations in altered level of consciousness, and those include the following. First is akinetic mutism. This is a state of unresponsiveness to the environment in which the patient makes no voluntary movement. In a persistent vegetative state, the unresponsive patient resumes the sleep-wake cycle after coma but is devoid of cognitive or affective mental function. A minimally conscious state is similar to persistent vegetative state but has inconsistent but reproducible signs of awareness. Finally, in locked-in syndrome, there's paralysis and the inability to speak, but vertical eye movements and lid elevation is intact. Here's a table providing a little bit more detail on the variations of altered level of consciousness. In terms of the etiology, altered level of consciousness can occur with diffuse hypoxic or ischemic encephalopathy, diffuse axonal injury, brain herniation, widespread infection, massive brainstem hemorrhage or infarction, central pontine myelinosis, which occurs with sodium imbalance, electrolyte imbalance, especially hypoglycemia, exogenous toxins, seizures or postictal states, and endocrine or metabolic dysfunction. The mnemonic COMA provides a really good summary of the etiological factors associated with altered level of consciousness. I stands for infection, T for trauma, S for seizure, C for cerebrovascular accident, O for overdose, M for metabolic, and A for alcohol. The assessment for altered level of consciousness is relatively extensive. It includes the following aspects: a thorough and accurate history, a neurological examination, an AVPU assessment or Glasgow Coma Scale, labs, a CT of the head without contrast, lumbar puncture, and MRI of the brain or EEG. In terms of the neurological exam, the following components are essential to assess: respirations, eyes, including an assessment of the pupils, extraocular movements, and the corneal reflex, facial symmetry, signs of meningismus, which we'll discuss later with the meningitis portion of this series, response to noxious stimuli, deep tendon reflexes, the Babinski reflex, and posture. Posture is of particular importance because there are two forms of posturing that signify a significant underlying problem. In decorticate posturing, the individual moves their upper extremities to the core. In decerebrate posturing, the individual is celebrating, with extremities moving outward. Although not the most appropriate way to think about this form of posturing, it does help with recall. Of the two forms of posturing, decerebrate posturing is the most severe, as it indicates a problem within the midbrain or pons. The Glasgow Coma Scale provides an objective measurement of level of consciousness. There are three sections of the scale described here. This is by far the most ubiquitous form of level of consciousness assessment. The best score you can obtain with the Glasgow Coma Scale is a 15. Any score less than 8 is indicative of a comatose state. And when the score is 3, the patient is completely unresponsive. Here's a little more detail with regards to the labs that may shed light on the etiology of the altered level of consciousness. Blood glucose may show you if there's underlying hypoglycemia or diabetic ketoacidosis. In terms of electrolytes, sodium can tell you whether or not there's potential for pontine myelinosis, and calcium, whenever it's high, it produces an inhibitory effect, which can alter the level of consciousness. BUN and creatinine can tell you if there's a uremic encephalopathy. The CBC with cultures can tell you whether or not there's infection, and this becomes particularly apparent in the elderly population who respond with mental status changes in the presence of infection. Liver function testing with an ammonia level can tell you if there's hyperammonemia with hepatic encephalopathy. The arterial blood gas will tell you if there's CO2 narcosis, hypercapnia versus hypoxemia. A tox screen or UDS can tell whether or not this is substance-induced, and the TSH and T4 can let you know if there's underlying hypothyroidism. A CT of the head without contrast is always the first form of imaging in the presence of any mental status change. In the cerebrovascular accident lecture, we will discuss why this is the case. For now, just know that the CT of the head can reveal any acute pathology that may have produced the altered mental status. This CT of the head reveals an intraparenchymal or intracerebral hemorrhage, often abbreviated ICH, indicated by the white area on the scan. In terms of the management of altered level of consciousness, the first priority is airway breathing and circulation. It's generally accepted in practice that if the GCS is less than 8, intubate. Otherwise, maintain an oxygen saturation greater than 90% through supplemental oxygen. The mean arterial pressure should be maintained greater than 65 millimeters of mercury. The next step is to check labs and do a neurological assessment, and then management should shift to targeting the reversible causes of altered level of consciousness. This is often recalled by the mnemonic DON'T. D stands for dextrose, O stands for oxygen, N stands for naloxone, and T stands for thiamine. Two additional measures include the administration of mannitol for increased intracranial pressure or herniation, and A for activated charcoal with gastric lavage if there's drug intoxication. Next, the patient should undergo a CT of the head without contrast for questionable structural causes. Then a more detailed history and systemic examination should occur, with potential follow-up diagnostics including an electroencephalogram, a lumbar puncture, and/or an MRI. The primary goal is to identify and treat the underlying cause. Otherwise, supportive care measures should be implemented. These measures include the following: protection or seizure precautions, fluid and nutritional support, oral care, maintaining skin and joint integrity, preserving corneal integrity, maintaining body temperature, preventing urinary retention, and promoting bowel function. Finally, you'll want to institute measures to prevent potential complications. These complications include respiratory failure, pneumonia or aspiration, pressure injury, venous thromboembolism, and contractures. Maintaining the airway and providing supplemental oxygen can prevent respiratory failure. Pneumonia and aspiration can be prevented by oral hygiene, as well as administering a proton pump inhibitor or H2 blocker, and being cautious with nutritional support. Pressure injury as well as contractures can be prevented by turning the patient every 2 hours, as well as doing range of motion. Venous thromboembolism can of course be prevented by SCDs or Lovenox or subcutaneous heparin therapy.